You can close this light, I think. This one there? Yeah.
We're good to go, sir.
Keep my mobile here.
Sir, we're good to go. Sir, we're good to go.
Hello. Good evening, all. Myself, Dr. Malay Mishra. Today, I have been getting that opportunity to introduce one of our emergency doctor. His name is Dr. Kiran Kumar Varma. He has done his MBBS from Narayana Medical College, MD from Emergency Medicine from Vinayaka Mission. He has done his ME, MEM and Diploma in Emergency Medicine from RCGP UK. He is also currently working as HOD Emergency Department at Yashoda Hospitals, Somajiguda. And he has got many achievements like Best Young Presenter Award from American College. He has received Vidya Ratna Award and Dr. APJ Abdul Kalam Award, Lifetime Achievement Award. Many publications he has. So today, without wasting much time, I am going to invite him. Today we are having a very beautiful topic. So I would request all the participants to listen carefully so that it will be useful for all of us to practice in a daily basis. Thank you. Over to you, Dr. Kiran.
Yeah, thank you, Dr. Malay. Thanks for your kind and nice intro. Thank you so much. Hello, good evening, everyone. Myself, Dr. Kiran Varma, working as Head of the Emergency, Yashoda Hospitals, Somajiguda. So I welcome you for this series of webinars conducted by Yashoda Group of Hospitals on every Friday. So it's my pleasure to be there in front of you to deliver my talk on USG guided procedures in emergency department. See, being an emergency physician or resident, so we use ultrasound right and left in each and every day, almost for each and every patient. So it is like another stethoscope for us. So sometimes you might or might not use stethoscope, but we use ultrasound for sure for majority of the patients in ED. So now our topic for today is what are the procedures we do under USG guidance. See. So objective of this session for today to know about the various USG guided procedures in our emergency department. So there is a little bit, there are a few differences of being ultrasound machine which is used in emergency and critical care. See, when it comes to critical care, they focus on cardiac, thoracic, vascular for a diagnostic and screening purpose of abdomen, and sometimes they use for procedural guidance. In critical care, it would be useful for initial and distal examination for ongoing diagnosis and management. It does not lead to decision to discharge from the hospital for critical care team. But when it comes to emergency department, it includes all critical care ultrasonography, as I told earlier, for critical care sonography. And we extend it for abdomen, testicular, obstetric, musculoskeletal, ocular procedure, and for many procedures guidance. Typically, this ultrasound gives us a clue. So whether to regarding diagnosis, based on that, we can dispose the person from ED itself. So emergency ultrasound can be classified into the following functional clinical categories. One is resuscitative. So we use ultrasound for many resuscitative procedures, especially then fluid resuscitation. So we do IVC collapsibility. If IV is collapsible, we'll give the more fluids. So like that. So there are many resuscitative things we can get help from ultrasound. Then diagnostic. See, we can diagnose many things in ultrasound by doing ultrasound in our emergency department. Like example, pneumothorax. So which we can check the barcode sign, absence of sliding sign. With that we can diagnose tension pneumothorax. Then if there is a free fluid in the abdomen, like hematorenal, splenorenal pouch, so we can detect some solid organ injury following trauma or something like that. Then sometimes patient symptoms are science based, which helps a lot. For example, there is a patient with a history of SOB. So we don't know the exact reason for SOB. In such scenarios, we can follow the blue protocol. So with that, now we can get a lot of clues towards the diagnosis. Then procedural guidance. Of course, we do visit the procedures under ultrasound guidance only, like central line, and then pericardiocensis. There are many things which we perform under ultrasound. Then therapeutic monitoring, like using therapeutic physiological monitoring as well. Example, so we are given the fluid. So whether the patient has physiological response, then we'll check the IVC, whether it is filled or not. Then sometimes tachycardia, then AF. Then if there are something like clot in the ventricles, so those things, it would be helpful for us to monitor. So when you're using ultrasound, 3 basic steps should be known. So one is like probe selection orientation. So you should know what probe you are going to select for our case. Then you should know about the orientation. So as you all know that probe have different kinds of probes, like high frequency probes and low frequency probes. Then high frequency has less penetration, low frequency has deeper penetrations. For superficial structures, we use high frequency probes, like linear probes. Then orientation, then probe marker you should be very conscious about probe marker. Otherwise, that anatomical variation will be altered. Right become left become right, medial become lateral become medial. So you should be very careful about probe selection and orientation. So I'll tell you one thing, that probe marker should be always pointing towards the right side of the patient or towards the head of the patient. So you should keep in the mind. Then second one is image orientation. So what type of axis you want, whether it is longitudinal axis or transverse axis. Then third one you need to remember is in plane technique or out of the plane technique. So I request our people to go with in plane technique, so that you will know the entire, if you are going, example, if you are doing in plane technique, you will be knowing the needle length, depth, how it is going, where it is going. So whether it is touching the artery, vein, or you will come to the entire course of the needle if it is in the in plane technique. Out of the plane techniques, there are many disadvantages. One among is we couldn't know the entire course of the needle if you are doing central line. So 3 things. One is probe selection and orientation, image orientation, then in plane or out of the plane techniques. Then before you are doing any procedures under ultrasound guidance, this is the mnemonic you should keep in the mind. EASC mnemonic. E stands for examine for the best location. A stands for the anesthetize early. Third one is stick with the angle. Then fourth one, evaluate for the placement. So when you are going to perform any procedures, first examine for the best location, which is the best location to perform the particular procedure. Then anesthetize early. So without giving local anesthetics, don't try to attempt any kind of procedure on conscious patient. Then stick with the angle. So this is one of the crucial step when you are performing any procedures. So you will be knowing where to place the probe, then anesthetize, then this is the time to introduce the needle. Then you should know about the angle properly. So initially we maintain the angle, but after some time with your probe orientation, when you rotate the probe, that angle will go off. Once you miss that angle, you tend to hit unwanted structure. So you stick with your angle. Then evaluate for placement. After placement after successful of placement, you should confirm whether it is in the desired location or not. So this is the EASC mnemonic you should remember. When it comes to our procedures, these are the various procedures we do perform in emergency department under ultrasound guidance. So our bread and butter for emergency people, then many people are, especially our residents, are very interesting. They are hyper into about getting central line chances. So that is one. Vascular access, it might be a peripheral or central. Then second one is like pericardiocensis, then paracensis, it might be abdominal or thoracocensis. Sometimes bladder aspirations, then orthocensis, thoracocensis. Sometimes we do detect foreign bodies with the help of ultrasound. Then abscess identification and drainage, then regional blocks. So apart from all these procedures, what I mentioned here, there are many procedures which we do perform regularly. But since we have a constriction of time and a congestion of time and all, we discuss about certain procedures we do perform in emergency department. So vascular access, so as I told you, it might be a central access or peripheral vein access. If it is central vein access, we select for internal jugular vein, subclavian, femoral. Then sometimes if it is difficult peripheral vein access, then we take the help of ultrasound. Then arterial lines. So major times we get succeeded with blind techniques. If you're unable to get in blind techniques or difficult arterial access, please consider ultrasound. So these are the vascular access. See, before going for any venous vascular access, you should know whether it is vein or not. You should be able to differentiate. See, now I'm going to talk about central venous access. So yes, now we are ready to go with the central venous access. So we keep everything ready. Then this is the time to go for the access. So without knowing the structure, what it is, whether it is artery, whether it is vein, then there is no point of doing the ultrasound guided vascular access. Just hold me. Sorry. Sorry, there was a technical error. Please bear with me. So actually, this is a video which is I'm unable to play. So this is which I want to show it like to differentiate between the artery and vein. See, if it is artery, so usually how do you differentiate between artery and vein with the help of ultrasound? Very simple. So vein is collapsible with a minimal pressure, so artery will not get collapsed. So don't say that pulsatile one is artery, then non-pulsatile is vein. So that is kind of, no, it is not at all correct. So only thing, if at all you want to differentiate, is vein is compressible with a minimal pressure, artery will not get compressed. So that video I'm unable to play, sorry for it. So here you can see it. One is artery, then another one is vein. So it is not about the color coding. Blue is vein, red is green. See, this is the thing which you keep in the mind. So we have different notion regarding ultrasound, especially color flow. If it is a blue, that is a vein. Red, it is a artery. No, it was not like that. Any flow towards the probe, it gives red. Away from the probe, it gives blue color. You think that this is the vein, which is, so for example, blue, which is the blue in color might be the vein. So which I am able to play the video. So if you have seen that video, it have differentiated by now. For our understanding's sake, blue is the vein, which is getting compressed on minimal pressure. Then another one which is showing red color is like a artery, which is not get compressed on minimal pressure. This is the short axis. Then we turn it into the longitudinal axis. Then another picture. So down one, bottom left side, you can see the needle. So this is implant technique. This is advantage of implant technique. So implant technique means the needle which grows across the longitudinal axis of the probe vessel. So you can see the entire course of the needle. So how it is going, where it is going, so that it will be easy for you to manipulate the needle, so that it can minimize the chance of pricking of unnecessary structures like artery and all. So that is one of the central vein axis. When it comes to peripheral vein, usually we don't use ultrasound for the peripheral vein axis. Certain situations like difficult peripheral vein access, then you can consider ultrasound. So these are the places where you place peripheral venous access with the help of ultrasound: cephalic vein, brachial vein, and basilic veins. Same. So how we differentiate between artery and vein, we can differentiate such a way. Then we can locate the vein. Then you can secure the peripheral vein access. So another procedure like a pericardiocensis. Here I would like to ask you one question for all our viewers. Whoever is going to answer first. So I will give you, what is that? So I'll give you the free subscription for the upcoming webinar, not webinar, for an upcoming seminars or CMEs or conferences, which I'm going to conduct in a couple of months. So what is Bextride? Just type your answers in the chat box. So whoever is going to answer the first. So I'll give you the free subscription for our CME or conference, which I'm going to conduct in a couple of months. You can type your answer in chat box. What is Bextride? Okay, you just type it. So this is one of the procedures we do perform in emergency like pericardiocensis. If there is a pericardial tamponade, especially pericardial tamponade, then we can consider pericardiocensis. So all pericardial effusions are not pericardial tamponates. If at all you want to say it is a pericardial tamponade, there should be a RV collapse with hemodynamic instability. Then only you can call it as a pericardial tamponade. So that is emergency. So there you have to intervene at the earliest. Otherwise, you are going to lose the patient. So in such scenarios, you can do the pericardiocensis. So here I'm not going to teach about the technique of doing the pericardiocensis. Just to give you the insight about pericardiocensis, how to do it under ultrasound guidance. See, this is the angle 30 to the subsified. You can place your needle in the subsified region, then 30 to 45 degrees angle. So pointing towards the left shoulder, then advance. Then once you withdraw the blood, then you can confirm whether it is in the pericardial sac or not. See. So first one, visualize these are the 4 steps you need to follow. One is the visualize the pericardial effusions. Then second one, just to confirm the placement of the needle by aspiration of blood. Then directly visualize the needle tip under ultrasound. Then another test is called bubble test. Just get the agitated saline. Then if you introduce into the pericardial space, then you can see the bubbles. It means that if those bubbles are there in the pericardial space, it means that you are in the right place. So this is one of the tests. So with that you can confirm whether the needle tip is in the pericardial sac or not. Then third step is like then you can introduce the place where you can see the guide wire here in the step 3. This is the guide wire. Then fourth step, then place the catheter using the Seldinger technique. So here one of the tip is do not aspirate all the fluid prior to the placement of the catheter, because so once if at all you are going to remove the entire fluid before placement of catheter, then it is very difficult for you to know the catheter is in the place or not, because you are unable to aspirate anything since you have aspirated already. So make sure that don't aspirate all the fluid prior to the placement of the catheter. Then, so what is the confirmation whether you have succeeded or not? Then the 2 things you have to keep in the mind that one, decreased effusion size. Initially there was in size about so and so. Then you place the pericardiocensis catheter is in the place. Then you aspirated the fluid. Then you can see the reduction of the there is a decreased effusion size. Then another one is improved hemodynamics. So these are the 2 things which gives clue successful pericardiocensis. This is one of the procedures we do. Actually, this is the video. I'm unable to play it here. Some technical error, sorry. Then another one is like a thoracocensis. So which we do. Then another question for you. If there is a massive pleural effusion, so what sign do you expect? What sign do you see on the ultrasound, chest ultrasound? This is one more question for you. So what is the sign do you see when there is a massive pleural effusion? Then next one is, so what is the other uses of ultrasound? What are the other things we do perform? Like a foreign body detection. See, there will be a foreign body like, stone, wooden pieces, and needles, something like that. So how do you detect? I'll give one clue. All soft tissue foreign bodies are initially hyperechoic on ultrasonography. All soft tissue foreign bodies are initially hyperechoic. But over a period of time, it became less echogenic, especially wooden foreign body, something like that. Then one more clue. So objects with a small radius of curvature or rough surfaces results in clean shadowing. I'll show you the difference between clean shadowing and dirty shadowing later. Objects with a large radius of curvature or smooth surfaces results in dirty shadowing. So the wooden toothpicks or pencils, something like that, will give you the clean shadowing. Then glass and metals, which gives dirty shadowing. Here you can see it. The first one is the sewing needle. So a patient has come to here with a history of some unknown prick which has happened. So on examination, there was a tenderness or the plantar aspect. So on subject him to for X-ray, you can see the needle here, the first thing. See, hyperechoic in the entire course of the needle. So this is an ultrasound. Then how do you detect it on ultrasound? You can see it, right? Hyperechoic thing. You can see the arrow in the first thing, just below the sewing needle X-ray image. You can see the arrow. This is the hyperechoic. So it gives, so as I told you previously, clean shadow. This is the clean shadow. This is the clean shadow which gives. So this is also clean shadow. The second one, wooden piece shadow. Then third one, you can see it, stone. So there is a stone in here, so which gives rough shadow or dirty shadow. So these are the differences between clean shadowing and dirty shadowing. So okay, we can go with the needle. So here is the needle on X-ray. Then when you do the ultrasound, you can see the hyperechoic thing, which is marked with the arrow mark. So which gives clean shadowing. Then another example like a wooden piece on X-ray of the foot. So there was we couldn't appreciate any foreign body on X-rays. But when you do the ultrasound, you can see the hyperechoic one, then followed by the clean shadowing. So with that, you can detect wooden pieces. So usually wooden pieces we wouldn't be able to detect on the X-rays, but with the help of ultrasound, we can detect the foreign bodies. Then another one is stone. Third one. On X-ray, you can see the small portion of stone, which is easily appreciable on X-ray. Same thing, if you do the ultrasound for the same guy, you can see the hyperechoic here, which is marked with arrow, then followed by the dirty shadowing, kind of dirty shadowing. So with that, you can differentiate whether it is needle sharp object, then rough objects, something like that, we can differentiate. Then fourth one is the plastic materials. See, if you perform X-ray for the same patient, you couldn't appreciate anything on the chest X-ray, which is, so plastics were unable to detect on the chest X-ray, X-rays. Then if you do the ultrasound, you can see the dirty shadowing. This is called dirty shadowing. You can see some small sort of hyperechoic, hyperechoic lesion here, then followed by the dirty shadowing. So this is how we are going to differentiate between different foreign bodies. One is like a sharp objects like a sewing needle, then wooden piece, stone, plastic material, something like that. So then another process we do perform on our emergency department, suprapubic bladder aspirations. So there is a patient with acute retention of the urine. You tried for Foley's catheterization with varying sizes, but you couldn't succeed. So patient was in agony, patient was a discomfort. Then next choice for you, next choice for you is like a blood aspiration. If there is a chance for suprapubic catheterization, is well and good. If there is no chance for the suprapubic catheterization, then you have to relieve him from agony or discomfort due to blood retention. The next immediate step is to do the suprapubic bladder aspiration. So this is one of the easiest procedures which we could do easily in our EDD. So for that, you need to have low frequency probe or cardiac or curvilinear or cardiac probes. Usually you go with the curvilinear probe, which is low frequency. Then as I told you earlier, probe marker always has to point towards the end of the patient. Then you can see the long axis of the bladder. In the second picture, if you see, this is the patient head. Then another one is like a patient's feet. Then we are introducing the needle just to go few centimeters above the pubic symphysis. Then introduce the needle under ultrasound guidance. So here you can see the needle which is advancing. You can see the hyperechoic needle structure. You can see it. So once you enter into the bladder, then you start aspirating the things. You can see the things here. Sometimes there will be a blockage of, sometimes we are unable to remove the Foley's catheterizations. Sometimes we are unable to deflate the Foley's bulb. In such scenarios, also, the ultrasound is very much helpful to remove the Foley's catheterization. So one easy technique is, first you need to locate the bulb, Foley's bulb, which is round in shape. You can see it here. You can appreciate it. It's like a balloon, Foley's bulb here. Then once you locate it, so get a needle, then try to pierce it, try to puncture it. So once you puncture, the fluid which is there in the bulb, which goes out of the bulb, then it gets deflated. Then you can remove the Foley's catheter easily. So that is also one of the technique we followed. So I think I did multiple times when I was doing my MD. So this is one of the helpful procedure which helps the patient when patient is in agony due to acute urinary retention. Then orthocensis. So usually we don't perform, but in majority of the centers, so being emergency physicians, so we might get a chance to do orthocensis. So there is a patient has presented here with history of swelling and edema and all. Then diagnosed to have there is a fluid accumulation in the joint space. So if you are going to withdraw the fluid from the joint space, then it gives lot of comfort to the patients. So these are the places where we can do orthocensis, like knee, ankle, hip, and elbow. So these are the common locations which where we can perform the orthocensis. But majority of the places we are not doing it. Very few centers only they are performing orthocensis using ultrasound. So anything, first you should locate the anatomy. Then you should know about the anatomy properly. If it is like a knee, then you should look for quadriceps muscle, then femoris and patella. Then if there is a free fluid, then you can do it. So so one more thing you can appreciate here is, you can appreciate the needle. It is implant technique. So the needle is coming from this end to entering into joint space. Then you can aspirate the thing. Simple technique is just to follow the implant technique. Then you should have some knowledge regarding the anatomy of the particular joint. So then it will be easy for you to do orthocensis. Then IND, incision and drainage for abscess. So actually this is the ED procedure, but unfortunately majority of our ER team, ED residents or consultants not doing. So we are giving it to the surgeons, but this is one of the procedure for us. So there are abscess in our body. The three common abscess like breast abscess, underarm, and gluteal regions. So if at all you want to do IND for abscess patients with the help of ultrasound, we should differentiate among cellulitis, cyst, or pseudoaneurysm. Sometimes if you are unable to appreciate whether it is cellulitis, whether it is cyst, whether it is abscess, then there is no point of doing IND. Then how to differentiate between cellulitis, cyst, then how to differentiate between abscess and cyst, I will let you know in the coming slides. So this is the cellulitis. So when you keep your ultrasound on the leg suspected to have cellulitis, in the early stage of cellulitis, there is increased echogenicity of the skin and subcutaneous tissue. You can see it here. See, this is the left leg normal. You can see the differentiate. You can see the difference between normal and cellulitis. The first picture on the left side, that is cellulitis. There is increased echogenicity of skin and subcutaneous tissue. So it gives information regarding the early stage of the cellulitis. But when it goes on to the later stage of cellulitis, you can see the cobblestone appearance of the skin. The reason for cobblestone is, so after some point of time, the cells will get separated due to accumulation of the fluid secondary to the inflammation. So because of fluid accumulation between fat globules and all these structures, the typical appearance of cobblestone will appear. So this is the differential between early stage of cellulitis and late stage. Early stage means there is increased echogenicity of skin and subcutaneous tissue. In the later stages, you can see the cobblestone appearance. So if any of the one, like increased echogenicity of skin or cobblestones, it could differentiate between cyst and cellulitis or abscess and cellulitis. Now, so how to differentiate between cyst and abscess with the help of the ultrasound? In the left picture, you can see this is the cyst, well circumscribed. You can see it here. Then right side of the picture, this is abscess. The thing which you need to remember to differentiate between abscess and cyst is, in the cyst is anechoic. Anechoic, so you can see it, anechoic, see black colored one. This is anechoic. Then when it comes to the abscess, there will be hyperechoic. You can see the hyperechoic things in the cyst, I mean in the center of the lesion. That is how you can differentiate between cyst and abscess. So easy to remember, cyst is anechoic, abscess is hyperechoic. So once you confirm the diagnosis of abscess, then you can go ahead with the aspiration of the abscess. So you can see it here in the down picture, no? You can see the needle is entering into the abscess area. Then you can aspirate the fluid, which you are able to do it. Then sometime if you are unable to aspirate the abscess, then you can go with the incision and drainage as well. But before that, as I told you earlier, you should differentiate among cellulitis, cyst, and abscess. Actually, this is the video which I performed during my PhD, but I couldn't able to play the videos. Some technical glitch. Right from first slide, there is a beautiful videos of central venous access, then pericardiocensis, then abscess. Sorry, I couldn't make it. Then comes to the regional blocks. So this is one of the recent trends in the field of emergency medicine. So we started practicing regional blocks at many centers. Actually, we have been doing since last 5 to 6 years, but because of various reasons, we are not doing at this point of time. But we hopefully will do in the future as well. So this is one of the regional blocks. So there are many advantages of regional blocks, especially when you compare the general anesthesia and other drugs, analgesics, sedatives drugs. So it doesn't have systemic effects. It's easy to perform. Then we don't need to keep the patient in ED for observations hours or days together. But before doing regional blocks, you should be able to locate the nerve properly. Then here one more question for you all. So how do you recognize the nerve with the help of ultrasound? So how does it appear? How does it look like on ultrasound? So how do you how do you identify the nerve with the help of the ultrasound? How does it appear? That is one thing. Okay. Yes. Now you are able to recognize the nerve, then vein or artery. Yes, once you recognize the nerve, then you have to infiltrate the local anesthetic around the, we have to infiltrate around the nerve. Make sure that it is not entering into the venous or arterial. Yes, I'm going through your answers. Okay, we'll do it later. Yes, you can see it here. This is the first picture on the upper column, left and right. This is called honeycomb appearance. In the ultrasound, nerve appears as honeycomb. So with that honeycomb appearance, you could differentiate between nerve, vein, tendons. You could differentiate. See, sometimes now we tend to infiltrate anesthetic drug into the tendons as well. So to avoid such kind of things, so first you should recognize whether it is nerve, vein, or tendon. As you people, as major people told that honeycomb appearance. So with that we could differentiate whether it is nerve or artery or tendon. The one of the easy technique to remember for reasonable blocks. First, you appreciate the arterial pulsations. Arterial pulsation, then majority of the times, the nerve will be there around the vessels. It's like almost neurovascular sheath. When there is a vessel, there will be a nerve. Some approximate, very close to each other. So you feel, if you are unable to identify the honeycomb appearance, then feel the pulse, then infiltrate just a few centimeters, few distance away from the vessels, they infiltrate around it. Make sure that the anesthetic drug is not entering the artery or vein. That is one thing. So there are multiple nerve blocks where we use scalene blocks, then for INDs, then fractures of upper limb, lower limb. There are different regional blocks. So where we get a lot of advantages. So here only thing you need to remember is honeycomb appearance. So these are the procedures we do in our emergency department. So there are many more. So what we didn't discuss, it doesn't mean that we are not doing, since we have a short time. So the things which could be possible to cover within a short span, I covered it. There are many things we will discuss in the next webinar as well. So with this thing, this is our take home message, like we should know normal anatomy and its appearance on ultrasound. Otherwise, it becomes like a catastrophe. If we don't know normal anatomy, then how to detect it on the ultrasound. Then proper probe selection, as I told you, is mnemonic. Then avoid wrong procedures on wrong patients at right time. Avoid correct procedures on correct patients at wrong time. So both are wrong. So this is a take-home message. If you have any questions, we can take it further. Thank you. Thank you, Dr. Malay. Any questions you can take up?
Thank you, Dr. Kiran. It was just such a wonderful and lucid interactive sessions. And I hope all the participants will ask many questions. These days, ultrasound is act as a stethoscope, as you mentioned clearly. So it's a new tool for everyone. I'm expecting a lot of questions here now.
So my apology for all the viewers. I am unable to play the videos. There are beautiful videos. So how to differentiate vein, artery, then how to do vascular catheterization. So what is in-plane technique, out-plane technique. So I had beautiful videos which I couldn't play it here. So anyhow, I'll forward on the groups as well. So one of our guys is asking for the videos.
Yeah, someone has requested for that. We'll send videos in WhatsApp.
Then
Sir, you can
Malay. So do you have any inputs regarding the same?
sir, you can share the PPT once again and click on the optimize for video clips checkbox, then share, then the video will play.
No, I tried, but I couldn't.
Okay.
Okay. Malay, any inputs from your end?
Yeah,
Any
it was like
suggestions,
wonderful
any tips
sessions.
to
As you have
perform any procedures?
clearly mentioned the ultrasound guided central venous catheter. This is the era like people should do it for all the procedures. They should use ultrasound. Even for suprapubic catheterization, as I clearly mentioned, it is very, very essential because persons will be having acute retention of urine. And with the help of USG, we could able to relieve like by putting some needle into the bladder. So it will be great relief for the patient. That procedure should be known to everyone. Second thing is pericardiocentesis. As you have clearly mentioned, this is a obstetric shock and patient will be having hemodynamic instability. There will be hypotension, there will be muffled heart sounds. And so it is as early as better. You can put the probe and looking for the initial, like there will be free fluid around the pericardium. If you can put a needle and draw certain amount of blood, the patient will be relieved. So it will be a great thing for the patient presented to emergency in obstetric shock. And for like abdominal centesis or thoracocentesis, these days also we are taking the help of ultrasound in a routinely manner, and we should take the consent, whatever the procedure we are being routinely done in emergency. Make sure you should have a proper documentations and proper consent is required before proceeding for any kind of procedures in emergency. And last but not least, you have mentioned that regional block. So these days it is very, very interesting, and people are in the conference and seminar also, they are implementing these regional block concepts everywhere. So you go to any big conferences like MCon, Semicon, anywhere you will get this workshop kind of hands-on procedures. So it's a really big things these days. And we all should adhere to these kind of practices because these are all evidence-based medicines. And once we practice, and it will be a habitual for all of us for better patient care and management.
Yeah, exactly, Dr. Malay. So any questions from our viewers?
Yeah, someone has asked what's the best approach for pericardiocentesis.
Oh, same subsified view. See, there are many techniques like you can use pericardiocentesis needle, then you can use, you can straight withdraw the fluid from the pericardial sac. That is one technique. Then another technique like catheter. So use the Seldinger technique, then place the catheter. First introduce the needle, then guide wire, followed by a catheter. So that is one thing. So best approach is subsified approach. So 30 to 45 degrees of angle. So going towards, pointing towards the left shoulder, then advance inch by inch, then withdraw the fluid. So once you confirm that it is in the pericardial sac, then introduce the guide wire. Then confirm it before doing catheterization, before inserting your catheter. You just confirm it, whether in the sac or it is, sometimes it might be there in the ventricles or atria. It will be in the cardiac chambers. So you have to make sure that. So that bubble test will help you a lot to differentiate whether tip of the catheter in cardiac chambers or in the pericardial space. It helps you a lot. So do the bubble test, then you insert your catheter. So Gautam, the new procedure which I have liked is urinary bladder retention due to catheter block. Thanks for the webinar. Oh, thank you, Dr. Gautam. So any other questions? So anyhow, I'll post my PPT on the groups as well. Or if you want to have any personal things, just note down my number 8297 545566. I'm just typing it here in our chat box 8297 545566. So if you request it on WhatsApp, I can share my PPT as well. Okay, Malay, if they don't have any questions, we can wind up.
Yes, it will be very much interesting, and it will be very much useful if you can share your PPTs to all the participants. And I think I must thank you again for your nice interactive sessions, and hope we should continue this in future. Thank you so much for all your efforts.
Thank you,
I
Malay.
hope all the participants, whoever are there till now. There's another questions like where we can see the webinar again. I think it will be posted in a group.
Groups, yes.
You can get all the access. Every Friday we used to have our seminars in Facebook also. Yes.
Yeah, it is in Facebook also. We'll share the link.
Thank you. Thank you so much. Thank you, Dr. Kiran. Thank you.
Thank you, Dr. Malay. Thank you so much.